Good afternoon. Today, we are going to learn more about the action potential. Last day, we have discussed the action potential, the different phases of action potential, as you have seen in a neuron, the resting membrane potential, the depolarization phase, the repolarization phase. Let's just revise them. For a neuron, the resting membrane potential is minus 70 millivolt. When a threshold current is applied to the membrane, what happens? There is influx of sodium ions. And when the stimulus is threshold, it is able to open up a critical number of sodium channels. Minus 55 millivolt potential is considered as the firing level. After that, the potential reaches nearly up to plus 40 millivolt. There is overshoot, but it doesn't reach the equilibrium potential for sodium ions because sodium channels are voltage and time dependent. After a certain time, what happens? They close. Before closing, they become inactivated. So sodium channels first become inactivated, followed by closure. The potassium channels, as we have learned, are slow to open, but they remain open for longer interval. So the sodium channels have become inactivated, potassium channels are open, so potassium moves out of the cell. This is responsible for your repolarization. In the lower part of the repolarization, the slope decreases because the concentration gradient gradually dissipates. But potassium conductance still remains. As a result, the membrane hyperpolarizes a bit, followed by returning to the resting membrane potential. So we have learned about the phase of depolarization caused by sodium channels mainly, and the phase of repolarization, which is caused by the opening of potassium channels. We know that the sodium channels are fast to open and fast to close, while the potassium channels are slow to open, but they remain open for longer interval. The sodium-potassium ATPase pumps also corrects the ionic distribution and brings back the resting membrane potential. Now, what is the latent period? After a stimulus is applied to a nerve, there is a latent period before the start of the action potential. This interval corresponds to the time it takes the impulse to travel along the axon from the site of stimulation to the recording electrodes. Its duration is proportional to the distance between the stimulating and recording electrodes and is inversely proportional to the speed of conduction. So this is about the latent period. Now let us see about some of the characteristics of the action potential. The action potential, you know, it begins in the initial segment of the axon because there are the number of sodium channel concentration is much more. It is always a depolarizing potential. It is not a graded potential or a local response. This graded local responses are graded potential. They can be summated. And they can be either depolarizing potential or they can be hyperpolarizing potential. Depolarizing potential like the excitatory postsynaptic potential. Hyperpolarizing potential like the IPSP, inhibitory postsynaptic potentials. But action potential is always generated due to depolarization. A threshold stimulus is required to generate an action potential. And after the threshold stimulus, however the strength of stimulus you increase, the response will remain same until the refractory period is over. So the action potential, it follows all or none law. So you can see here in this picture, again, just a revision, the sodium and potassium conductance of the membrane. The action potential, the absolute refractory period, and the relative refractory period. Till the 1/3 of repolarization, it is absolute refractory period. Because for production of an action potential, we require a critical number of sodium channels to open. And what has happened during the overshoot and all? Sodium channels have become inactivated until they completely close. However, the strength of current you increase, you cannot generate another action potential. This is the phase of absolute refractory period. Then comes the phase of relative refractory period. In this phase, some sodium channels are already closed. So if you increase the strength of current, you can open these channels. This is the relative refractory period. So absolute refractory period and relative refractory period. Sodium and potassium conductance of membrane, we have seen them. The action potential propagates without decrement along the axon. You can see in this picture, the shape of the action potential does not change as it travels along the axon. If this was a local response for an electrotonic conduction, what would have happened? After traveling some distance, it would have become insignificant. An electrotonically conducted signal dies away over a distance of few millimeters. The distance over which the potential change decreases to 1 by E, that is 37% of its maximal value, is called the length constant or the space constant. So that is called the length constant or the space constant. This E is the base of natural logarithms and is equal to 2.7 roughly. The length constant can be related to the electrical properties of the axon via cable theory. Why is it like this? Because nerve fibers have many properties of an electrical cable. In a perfect cable, the insulation surrounding the core conductor prevents all loss of current to the surrounding media, so that a signal is transmitted along the cable with undiminished strength. Now, if we compare an unmyelinated nerve fiber with an electrical cable, the plasma membrane equates to the insulation and the cytoplasm to the core conductor. But plasma membrane is not a perfect insulator. So the spread of signals depend on the ratio of the membrane resistance and the axial resistance of the axonal cytoplasm. The membrane resistance we will call it as Ra, and the axial resistance of the axonal cytoplasm as Ra, both in small. The higher the ratio of Rm to Ra, the less current lost across the plasma membrane per unit of axon length. The better the axon can function as a cable. And the longer the distance, that a signal can be transmitted electrotonically without significant decrement. Now, based on this cable theory, the length constant can be related to axonal resistance and is equal to root of Rm by Ra, that is membrane resistance by axial resistance of the axonal cytoplasm. With this relationship, we can determine how changes in axonal diameter will affect the length constant and hence how the decay of electrotonic potentials will vary. An increase in diameter of the axon will reduce both Ra and Rm. But Rm is inversely proportional to diameter, whereas Ra varies inversely to the diameter squared. So, Ra decreases more rapidly than Rm does as the axonal diameter increases, and therefore the length constant increases. So we have said that there is no change in size. That is, the axon, that the action potential propagates without decrement along the axon, while an electrotonic conduction, it has got a length constant or a space constant. So it decreases as it travels down the neuron. For a given neuron, the amplitude and the duration of the spike potential is constant, regardless of the stimulus. We already know about the refractory period. The refractory period in the neuron, the skeletal muscle, these are short. While in a cardiac muscle, we will see that cardiac muscles have got long refractory period. So the cardiac muscles, they cannot be titanized or fatigued. The refractory period is basically due to inactivation of sodium channels. The sodium channels for generation of action potential will require a critical number of sodium channels to open. Once the sodium channels become inactivated until they close, however the strength of current we increase, we cannot open them. So critical number of sodium channel opening is not possible. And so the period is absolute refractory period. Now let's see role of myelin. Myelin insulates the axon. So action potential jumps from one node of Ranvier to the next node of Ranvier. This is called the saltatory conduction. This grossly increases the conduction velocity. So what the action potential we have said, it is generated in the initial segment of the axon. And then if the nerve is myelinated, it will jump from one node of Ranvier to the next node of Ranvier until the synaptic knob or synaptic button by the process of saltatory conduction. But if in an unmyelinated neuron, it will be continuous conduction. The myelin sheath around many axons speeds up this process considerably. The myelin sheath is a multilamellar membrane which enwraps the axon in segments separated by intervals known as nodes of Ranvier and is produced by specialized cell, the Schwann cells, exclusive in the peripheral nervous system. Myelin sheath reduces membrane capacitance and increases membrane resistance. Myelin sheath prevents ions from entering or leaving the axon along the myelinated segments. So the myelin sheath increases the conduction velocity of the nerve fiber. You can see in this picture a myelinated neuron, a depolarizing stimulus has been given. What will happen? The impulse will be jumping from one node of Ranvier to the next node of Ranvier. This is saltatory conduction. If the nerve is not myelinated, there will be a continuous conduction. In this situation, the wave of depolarization and repolarization simply travels from one patch of membrane to the adjacent patch. So the conduction velocity will be much slower as compared to a myelinated neuron. Now there are some factors which can affect the conduction velocity. One is local anesthesia, blocked sodium channels. So movement of the sodium ions, no generation of action potential, continuous cold or exposure to pressure, blocked circulation, flow of nutrients and oxygen. So no energy for sodium, potassium, ATP is pumped to occur. As a result, no generation of action potential finally. Now, till now, whatever we have discussed, we have seen that we have put an electrode inside the cell and one outside the cell and recorded either the resting membrane potential or the action potential. And we have the resting action potential we have recorded in this way is monophasic action potential. Monophasic action potential. You can see in this picture here we have put the electrodes outside the membrane, both the electrodes. In monophasic action potential, when we recorded, we had put one electrode inside the cell and the other electrode outside the cell. Here, that is extracellular one is intracellular. In this instance, we are putting both the electrodes in extracellular space. So what is happening? We can see an electrical difference recorded out here. The action potential, this action potential is biphasic action potential. Biphasic action potential. You can see here the recordings of action potential. There is the difference in positive and negative voltages across the cell, and these are recorded by extracellular electrodes. One part becomes positive in respect to the other, while the other becomes negative in respect to the positive one. And this is recorded with the extracellular electrodes. This is biphasic action potential. Now we come to compound action potential. Compound action potential is recorded from a mixed nerve. You can see the picture, simple action potential, and in the picture on the other side, you can see compound action potential. So simple action potential and compound action potential. Compound action potential recorded in a mixed nerve. Now we will discuss about the action potential in cardiac muscle. So in different tissues, the action potential that you can see is different. So in cardiac muscle, the duration of the action potential is 250 to 350 milliseconds, while in the neuron we have said it is 2 to 5 milliseconds. In the cardiac muscle, you will see depolarization. There is some influx of calcium ions, while in the neurons you have said it is only due to because of influx of sodium ions. The resting membrane potential in cardiac muscle is minus 90 millivolt, while in a neuron it is minus 70 millivolt. Two main types of action potential occur in the heart. One type is the fast response, occurs in normal, atrial and ventricular myocytes and in the specialized conducting fibers, that is the Purkinje fibers of the heart. And this action potential is divided into 5 phases. This action potential is divided into 5 phases. So that is the fast response action potential. Fast response action potential. Now look at the picture. The rapid upstroke of the action potential is designated phase 0. So you can see here, this is phase 0. This is phase 0. This upstroke is phase 0. And then by a early repolarization. Here you can see there is early repolarization. Early repolarization. This is phase 1. Then you can see there is a plateau phase. Plateau phase. There is a plateau phase. There is a plateau phase out here. This is phase 2 that persists for about 0.1 to 0.2 seconds. The membrane then repolarizes. That is phase 3. Now we come to phase 3. This is repolarization of the membrane. Phase 3, repolarization of the membrane. Until the resting state of polarization, phase 4 is again attained. Now you can see phase 4. Phase 4 has been attained. So phase 0, depolarization, early period of brief repolarization, followed by the plateau phase, phase 2, then repolarization phase, bringing back to resting membrane potential, phase 4. Final repolarization, that is phase 3, develops more slowly than depolarization, that is phase 0. This was about the fast response action potential that you can see in the cardiac muscle. The other type of action potential is the slow response, which occurs in the AC node, which is the pacemaker of the heart, in the AV node, which is the specialized tissue that conducts the cardiac impulses from the atria to the ventricles. So that is the slow response action potential. This is the picture of the slow response action potential. The slow response cells lack the early repolarization phase. That is the phase 1. There is no phase 1. Other differences between the electrical properties of the fast and slow response cells are the following. Let's discuss them. The resting membrane potential, phase 4 of the fast response cell, is considerably more negative than that of the slow response cell. You can see here, it is much less negative. While in the first response, it was minus 90 millivolt. So that was much more negative. The slope of the upstroke, phase 0, the amplitude of the action potential and overshoot are greater in fast response than in the slow response. Here you can see this slope, the overshoot, they are less as compared to this one. You can see here the steep rise. The rise is more. Here you can see the rise is much slower. The action potential and amplitude and the stiffness of the upstroke are important determinants of propagation velocity along the myocardial fibers. In slow response cardiac tissue, the action potential is propagated more slowly and conduction is more likely to be blocked than in fast response cardiac tissue. Slow conduction and a tendency towards conduction block increases likelihood of some rhythm disturbances. So we have seen the different phases of the slow response action potential and the fast response action potential in the cardiac muscles. The various phases of the cardiac action potential are associated with changes in cell membrane permeability, mainly to sodium, potassium, and calcium ions. So as you have seen in all other cells of the body, the concentration of potassium inside the cardiac muscle exceeds the concentration of the ECF. And you know the potassium concentration in the ECF and the calcium concentration in the ECF is much more as compared to the ICF. Now, let us again revise these. The resting membrane potential of individual mammalian cardiac muscle is about minus 90 millivolt. You can see here it is about the resting membrane potential is minus 90 millivolt, minus 90 millivolt. Now, stimulation produces a propagated action potential that is responsible for initiating contraction. You have learned about excitation, contraction, coupling. Depolarization proceeds rapidly. You can see here, depolarization, phase 0, it proceeds rapidly. So there is a sharp rise and there is a overshoot. Same like you have seen in a neuron. But after that, you can see there is a small depolarization phase followed by a brief repolarization phase, which was not there. This brief phase, there was total repolarization of the membrane in the neuron. Here you can see there is a brief repolarization followed by the plateau phase, followed by the plateau. Then again, there is the repolarization phase. In mammalian heart, depolarization lasts about 2 milliseconds, but the plateau phase and repolarization last 200 milliseconds or more. Repolarization is therefore not complete until the contraction is half over. So repolarization is not complete until the contraction is half over. Changes in the external potassium concentration, that is, change in concentration of potassium in the extracellular fluid, affect the resting membrane potential of cardiac muscle, whereas changes in external sodium concentration affect the magnitude of the action potential. So potassium mainly contributes to the resting membrane potential of the cardiac muscle, while the action potential, the magnitude, is mainly dependent on sodium concentration. The initial rapid depolarization and the overshoot phase 0 are due to opening of voltage gated sodium channels that you have seen similar like that of the neurons you have studied before. The initial rapid repolarization, that is phase 1, is due to closure of sodium channels and opening of one type of potassium channels. So there is closure, this phase 1, there is closure of sodium channel and there is opening of one type of potassium channel. Now comes to phase 2. Now we come to phase 2, prolonged plateau. This is due to slower but prolonged opening of voltage gated calcium channels. So phase 2 is mainly due to opening of slower but prolonged opening of voltage gated calcium channels. Now repolarization, that is the final repolarization to the resting membrane potential. That is, phase 4 is due to closure of the calcium channels, a slow and delayed increase of potassium influx through various types of potassium channels. Now, cardiac myocytes contain at least 2 types of calcium channels. One is T type, another is L type. But the calcium current is mostly due to opening of slower L type of calcium channels. Mutations or dysfunctions in any of these channels can lead to different pathologies, serious pathologies of the heart, like the long QT syndrome. Long QT syndrome is defined as a prolongation of the QT interval that you can see in an ECG. It can lead to irregular heartbeats, subsequent fainting, seizure, cardiac arrest, and even death. So, abnormality of this channel can lead to different pathological conditions. Now, we will discuss in more details about the cardiac action potential. We know the resting membrane potential of cardiac muscle is minus 90 millivolt. The individual fibers are separated by membranes, but depolarization spreads radially through them, as if they are a syncytium because of presence of gap junctions. There is presence of gap junctions. So they act as a functional syncytium. The transmembrane action potential of single cardiac muscle fiber is characterized by, as we have already discussed, rapid depolarization, phase 0, and initial rapid repolarization, phase 1, a plateau, phase 2, and a slow repolarization, phase 3, that allows it to return to the normal resting membrane potential, phase 4. The initial, we will again revise, the initial depolarization is due to sodium influx through opening of sodium channels. The inactivation of sodium channel contributes to the rapid repolarization phase, and there is also opening of some potassium channel. Calcium influx through more slowly opening calcium channels produces the plateau. And repolarization is due to net potassium efflux through multiple types of potassium channels. Here we will discuss about multiple types of potassium channels. When recorded extracellularly, the summed electrical activity of all cardiac muscles, you can see them as ECG. ECG is a combined electrical record, and thus the overall shape reflects electrical activity from cells from different regions of the heart. Now, let's discuss about the pacemaker potential. Rhythmically discharging cells have a membrane potential that after each impulse decline to the firing level. So, rhythmically discharging cells, they have a membrane potential that after each impulse declines to the firing level. Thus, this pre-potential or pacemaker potential triggers the next response. So this triggers the next response. At the peak of each impulse, IK begins the repolarization, that is the potassium conductance. IK then declines and a channel permeable to both sodium and potassium is activated. Because this channel is activated following hyperpolarization, it is also called as A channel. But because of its funny character, it is also termed as F channel, and the current produced as funny current. As the conductance of this channel increases, the membrane begins to depolarize, forming the fast part of the pre-potential. You can see here the pacemaker potential, the pre-potential. So the first part is formed. There are two types of calcium channels in the heart. One is T type, that is the transient type of calcium channels. Another is the L type, that is the long-lasting channels. The calcium current due to opening of T channel completes the pre-potential, and the potassium conductance due to opening of L channel type of calcium channel produces the impulse. Other ion channels are also involved, and there is evidence that local calcium release from sarcoplasmic reticulum, that is calcium sparks, occur during the pre-potential. So we have learned about pacemaker potential, pre-potential. What are the ions involved in this part? The action potential in the AC and the AV nodes are largely due to calcium. In the neurons, we have said it is mainly due to sodium ions, with no contribution by sodium in plaques. So there is no sharp rise. Here the rise will be slow. There you have seen there is a sharp depolarization. Here you will not see there is a sharp depolarization. There is slow depolarization. Pre-potentials are normally prominent only in AC and AV nodes. But latent pacemaker potentials are present in other portions of the conduction system and can take over when AC and AV nodes are depressed or conduction from them is blocked. Atrial and ventricular muscles do not have pre-potentials, and they discharge spontaneously only when they are injured or they are abnormal. When there is cholinergic stimulation, that is vagal fibers to nodal tissues are stimulated, the membrane becomes hyperpolarized and the slope of the pre-potential is decreased because the acetylcholine released at the nerve ending increases the potassium conductance of nodal tissue. This action is done by M2 muscarinic receptors, which via beta gamma subunit of G protein open a special set of potassium channels. Sympathetic stimulation speeds depolarization effect, and the rate of spontaneous discharge increases. When there is sympathetic stimulation, norepinephrine secreted by sympathetic endings binds to beta-1 receptors and resulting increase in intracellular CAMP facilitates the opening of L type of channels and increasing calcium conductance and rapidity of depolarization phase of the impulse. So we will discuss the rest of the things on the next day. So you have learned about action potentials in neurons. You have learned about action potentials in cardiac muscles, the slow response, the fast response action potential. Go home and revise them, and we will see you next day. Thank you. Bye.